Hello students, good day to all of you. So today I will be discussing about the tibiofibular joints and the ankle joint, and also about the subtalar joints. Okay, so that is the remaining joints in the lower limb, the tibiofibular, the joints of the leg and ankle, and the subtalar joints. So our learning objectives for today, so naturally for any joint we will be discussing about the type of the joint, followed by its articulating surfaces, then ligaments or capsule, followed by the movements permitted in this joint or performed by this joint, and naturally the muscles which are producing these movements, then followed by it relations of the joint, nerve supply and blood supply, and finally the applied aspects. So first, to start with, we will be discussing about the tibiofibular joints. So if you look at the tibiofibular joints, the tibia and fibula are held together at three places. The upper part is actually superior tibiofibular joint, then you have the middle tibiofibular, and then you have the inferior tibiofibular joints. Okay, now of these, the superior tibiofibular joint is a synovial joint. It has got a joint capsule lined by synovial membrane, whereas the middle one is just the fibers which are holding it together, and the lower one is again a syndesmosis. So coming to the superior tibiofibular joint, is actually formed by the lateral surface of the upper end of tibia below the lateral condyle, or somewhat posterolaterally below the lateral condyle of the tibia, and between the medial surface of the upper end of the fibula. It is a synovial joint, which means you have a joint capsule and it is lined by synovial membrane. The type of joint is actually plane variety, so gliding movements. The tibia will glide over the tibia, the fibula will actually glide over the tibia above and below. Okay, so only some gliding movements are actually permitted in the superior tibiofibular joint. So as I told you, the circular facet below the lateral condyle, posterolateral part, and reciprocal circular facet on the head of the fibula. These are the articulating surfaces of the superior tibiofibular joint. Nerve supply is by nerve to popliteus muscle and the common peroneal nerve, because common peroneal nerve is intimately related to the head of the fibula, and then it is going to divide into superficial and the deep peroneal nerve. Before that, it gives a articular twig to the superior tibiofibular joint. Okay, so that you are able to see the superior tibiofibular joint, the anterior aspect and the posterior aspect. An anterior view and posterior view of the tibiofibular joint you are able to see here. This is actually the tibial tuberosity. This is the soleal line. Okay, this is actually the soleal line. Above the soleal line you have the popliteus muscle inserting, and along the soleal line you have the soleus muscle taking its origin. The next type of joint is actually the middle tibiofibular joint. Same like your middle radioulnar joint. Middle tibiofibular joint is nothing but the interosseous membrane which is holding these two bones together. So fibrous type, because this is mainly the membrane is made up of collagen fibers. So extending between the shaft of tibia, the lateral border, interosseous border of tibia, and the medial interosseous border of fibula, a membrane which is stretching is the interosseous membrane, which runs downwards and laterally. Okay. So the fibers of the interosseous membrane are directed downwards and laterally. Okay. Except in the upper part, the fibers are actually directed upwards. If you look downwards below, the ligament will be continuous with the interosseous ligament. The interosseous membrane will be continuous with the interosseous ligament of the inferior tibiofibular joint. Inferior tibiofibular joint. Okay. Then above you have an opening in the interosseous membrane for the passage of the anterior tibial vessels. Okay. You see the passage for the anterior tibial vessels, and below what happens, it is actually the opening, or it is pierced by the perforating branch of fibular artery. Perforating branch of fibular artery are also called as the peroneal artery. This perforating branch is going to take part in the malleolar network, lateral malleolar network. Okay. So for the anterior tibial vessels, and below it is for the perforating branch of the peroneal artery. Now what would be the relations? So in front of the interosseous membrane, so the extensor muscles which are taking origin, it will be related to tibialis anterior, extensor digitorum longus, and anterior tibial vessels and deep peroneal nerve. All these form the anterior relations for the middle tibiofibular joint. Behind, naturally, the deepest most muscle of the flexor compartment, the tibialis posterior, and the flexor hallucis longus will form the posterior relation for this middle tibiofibular joint. Okay. So that is the anterior relation, and then what you have is the posterior relation. So arterial supply is by anterior tibial vessels, and again perforating branch of the peroneal artery, which too passes between the gap in the interosseous membrane at the upper border and the lower border. Nerve supply again by nerve to popliteus. So the main function is holds the tibia and fibula together and resists the downward pull of fibula by the muscles. Okay. So because most of the muscles are actually taking origin from the fibula. Fibula is mainly for muscular attachments. These muscles, what happens is, due to their pull, mainly because of the gravity when you are standing upright, due to their pull, what happens is, it has the tendency to pull the fibula downwards, because all the muscles which are originating is again traveling downwards to the foot. So to resist this, the interosseous membrane is actually holding it, and that is the main function of the middle tibiofibular joint. The next joint of the tibiofibular articulation is the inferior tibiofibular joint. The inferior tibiofibular joint is again a fibrous type, syndesmosis. Okay, not even synchondrosis, because again it is a fibrous type. There is no joint capsule or synovial membrane, and both the bones are actually held together by the only the ligaments. The ligaments are mainly, before that, the articulating surface, the concave surface of the tibia, lower end lateral surface concave, and the convex surface of the fibula, convex above the malleolar fossa. Okay. So above the malleolar fossa, you see the convex surface is for the inferior tibiofibular joint. This surface is also called as the fibular notch. the articulating surface on the tibia for the fibula, inferior tibiofibular joint, is actually called as the fibular notch. Ligaments, mainly what you see is the interosseous ligament, so which is stretching between the bones, okay, between the tibia and the fibula. You see the interosseous ligament, and we have seen that the interosseous membrane below it is continuous with the interosseous ligament. This is for the perforating branch of fibular artery or peroneal artery, this gap. Now, the synovial recess, outpocketing of the synovial recess from the ankle joint extends up to 4 millimeter into this inferior tibiofibular joint. Same like we have seen in the wrist joint. You see a synovial recess extending into the inferior radioulnar joint. In the same way, here also you see a synovial recess extending upwards 4 millimeter from the ankle joint. So the main thing is the interosseous ligament, anterior tibiofibular ligament, which is present in front of the interosseous ligament, anterior tibiofibular ligament. Then posteriorly what you see is the posterior tibiofibular ligament. Same like this, in the front you have the anterior tibiofibular, and posteriorly what you see is the posterior tibiofibular ligament. Then you also have the inferior transverse ligament. Okay, this is actually the inferior transverse ligament, which is stretching across. It can be also called as the inferior displaced fibers of the posterior tibiofibular ligament. This inferior transverse ligament attenuates or increases or improves the concavity of the superior articulating surface of the ankle joint. It is also called as the tibiofibular mortise. Okay, I will come to that later, now while discussing about the ankle joint. So the ligaments of the inferior tibiofibular joint are the interosseous ligament, anterior tibiofibular ligament, and then what you have is the posterior tibiofibular ligaments. So the blood supply of the joint, perforating branch of peroneal artery and malleolar branches of anterior and posterior tibial arteries. Malleolar branch of anterior and posterior tibial arteries. Nerve supply, again it is from the nerve to popliteus, deep peroneal nerve and the tibial nerve. The nerve to popliteus, see how long it comes. It supplies the middle tibiofibular joint and the inferior and superior tibiofibular joints. That is the nerve supply of the inferior tibiofibular joint. Now action is during the dorsiflexion. What happens is, during the dorsiflexion, the fibula is displaced laterally and there is a slight outward rotation. That is the lateral rotation. At the same time, during dorsiflexion, there is gliding of the fibula over the tibia in the superior tibiofibular joint. Gliding movements in the superior tibiofibular joint during the dorsiflexion of the ankle joint. So that is about the inferior, superior and middle tibiofibular joints. So next we will move on to the ankle joint, synovial joint, modified hinge variety and a uniaxial joint. Okay, so uniaxial means movement only in one plane. So here movement is going to take place in only one plane, but it is a modified hinge joint. So that means some associated movements are also performed along with this primary movement. The ankle joint is also called as the talocrural joint because it is between the talus and the bones of the leg. So leg is also called as the crura. So that is why it is actually called as the talocrural joint. So you can see the shape of the articulating surface. The superior articulating surface is mainly formed by the tibiofibular mortise. So what is the tibiofibular mortise? Which means the inferior surface of the tibia and also the articular surface of the medial malleolus and as well as the articular surface of the lateral malleolus. Lower end of the tibia and the articular surface on the medial malleolus and the lateral malleolus all put together forms the tibiofibular mortise. You are able to see here the anterior view of the ankle joint, and this is the posterior view of the ankle joint. Now here you would like to note this is anterior inferior tibiofibular ligament, posterior inferior tibiofibular ligament. The detached part is the inferior transverse ligament. These transverse ligament, as I told you, increases the concavity of the superior articulating surface of the ankle joint or accentuates the tibiofibular mortise. Okay. So the superior articulating surface is the tibiofibular mortise, which is nothing but the combined articulating surface of the inferior surface of the tibia and the medial malleolus and the lateral malleolus. Now coming to the inferior articulating surface, it is actually the trochlear surface of the talus bone. The trochlear surface, trochlea means pulley. So trochlea means it is nothing but which is called as the pulley. So upper surface of the talus, which is called as the trochlear surface, it is wide anteriorly. You are able to see anteriorly the transverse or the width is wide, but posteriorly it is narrow. Then from before backwards or antero posteriorly it is convex, but from side to side it is actually concave. Okay, it is convex antero posteriorly, but it is concave from side to side. Then apart from that, it also has two facets on the either side, a comma shaped facet for the tibial malleolus. So this is actually the comma shaped facet on the medial side. You are able to see that is for the tibial malleolus. A small facet which is actually present only on the upper medial surface and anteriorly. Then you have a triangular facet which is somewhat extensive. The triangular facet is somewhat extensive and which is actually seen on the lateral surface. This is for the lateral malleolus of the fibula. So this is mainly for the lateral malleolus of the fibula. So these three articular surfaces together form the trochlear tali. So those articular surface is called as the tibiofibular mortise, and this articular surface which is on the upper trochlear surface and on either sides, triangular facet and the comma shaped facets put together form the trochlear tali. Coming to the ligaments of the ankle joint, so mainly capsule, interior of the capsule is lined by the synovial membrane. Medially you have the deltoid ligament and laterally you have the lateral ligament of the ankle joint, which has fibers of anterior talofibular, posterior talofibular, and then you have the calcaneofibular ligament. So the capsule of the joint is attached to the margins of the articulating surfaces, so mainly along the margins of the tibiofibular mortise superiorly. Inferiorly, it is again attached to the trochlear tali along the margins of the articulating surfaces. Laterally, what happens? The capsule is thickened, whereas antero-posteriorly the capsule is thin. Anterior and posteriorly the capsule is thin, but laterally it is thick and blends with the collateral ligaments. Something like your knee joint, you have the tibial and the fibular collateral ligaments. So you have the laterally, it blends with the collateral ligament. If you look anteriorly, what happens is the capsule extends. This is the articulating surface here, the trochlear surface, but it extends up to the neck. Okay, it extends a little bit forward onto the dorsal surface of the neck of the talus anteriorly. Okay, so one reason is the joint might get dislocated anteriorly. Anteriorly, it is a bit weak with respect to the ankle joint. So lining interiorly the joint cavity, you are able to see the joint cavity lined by the synovial membrane, but the synovial membrane ceases to line the articular cartilages. It ceases at the periphery of the articular cartilage. The remaining part of the capsule and the other remaining part of the bones, it is lined by the synovial membrane. If you look at both the malleoli, lateral malleolus is at a lower level as compared to the medial malleolus, and because of that only the talus has got an extensive triangular facet for the lateral malleolus, whereas from the medial malleolus it is not that much extensive and small, so that is why you have a comma shaped facet on the talus for the medial malleolus. The joint space, if you look at, completely corresponds with the level of the lateral malleolus of the fibula. So interior of the fibrous capsule is lined by the synovial membrane, and a recess extends into the inferior tibiofibular syndesmosis. Now coming to the ligaments, mainly two ligaments. One is the deltoid ligament and other one is actually the lateral ligament. So deltoid ligament is the medial ligament of the ankle joint. It is triangular shape and it has got superficial fibers and it has got the deep fibers. So since it is a triangle, the apex or the highest point of the triangle will be attached to the medial malleolus, and the superficial fibers, they diverge from the medial malleolus anteriorly into the navicular tuberosity, tibionavicular ligament or tibionavicular fibers, which will again merge with the spring ligament or plantar calcaneonavicular ligament. Spring ligament or plantar calcaneonavicular ligament, it merges with that ligament, the tibionavicular fibers. From the tip of the medial malleolus, it goes to the navicular bone. Middle fibers, tibiocalcaneal, going to the sustentaculum tali. It is a projection you will be seeing on the calcaneal bone. Posterior fibers, again from the tibia, medial malleolus to the talus, medial tubercle or medial surface of talus. This is the superficial part. Deep part, only anterior fibers, goes to the anterior part of medial surface of the talus. And this deltoid ligament will be crossed by tibialis posterior and flexor digitorum longus. This is your deltoid ligament, medial view of the ankle joint, triangular in shape. It is attached to the medial malleolus, the apex. Anterior fibers goes to the navicular, tuberosity of the navicular, and merges with the spring ligament or the calcaneonavicular ligament. Middle fiber, superficial part from the medial malleolus, goes to the sustentaculum tali. You will be able to see a projection, sustentaculum tali. And the posterior fibers is the tibiotalar, which actually goes from the medial malleolus to the medial tubercle of the talus. This is sustentaculum talli in the calcaneum. This is attached to the talus. Deep part of the fibers, it is actually called as the tibionavicular fibers. Sorry, the anterior deep part of the fibers. You are able to see here, that is the deep part of the deltoid ligament, which is again attached to the navicular, sorry, from the medial malleolus, it actually goes to the navicular bone. So that is about the deltoid ligament. The next ligament what you see here is the lateral ligament from the lateral malleolus. Again it has got anterior, middle and posterior fibers. The anterior fibers is actually the talofibular. From the lateral malleolus of fibula to the talus. Then middle fibers calcaneofibular. From the lateral malleolus to the tubercle on the lateral surface of the calcaneum. Then posterior fibers is actually the posterior talofibular fibers. From the lower part of the malleolar fossa to the lateral tubercle of the talus. This is to the lateral tubercle of talus. This is to the lateral surface of calcaneum. And this is actually to the neck of the talus. Lateral ligament. Anterior talofibular, calcaneofibular and posterior talofibular. Okay. So that is about the lateral ligament of the ankle joint. So mainly blood supply and nerve supply is by the anterior tibial, posterior tibial and peroneal arteries, which is going to take part around the malleolar network. Anterior tibial artery, posterior tibial artery and the peroneal arteries. Nerve supply is by deep peroneal nerve and posterior tibial nerve, which is crossing the joint. So naturally they will supply an articular tweak to the joint, deep peroneal and the posterior tibial nerve. So blood supply mainly supplying the ankle joint in the form of the malleolar network, which is given by the medial malleolar branches of anterior tibial, posterior tibial, lateral malleolar branches of anterior tibial, posterior tibial, perforating branch, lateral arcuate, lateral tarsal branch, arcuate arteries, all those. So here you are able to see the medial view of the ankle joint. Okay. So tibial arteries giving to the branches and lateral ligament will actually crossed by the peroneus longus. The medial side will be crossed by the tibialis posterior. The deltoid ligament is crossed by the tibialis posterior and the flexor digitorum longus. Relations. Anteriorly, very simple, structures passing deep to the extensor retinaculum. They form the anterior relations. Tibialis anterior, extensor hallucis longus, anterior tibial vessel, deep peroneal nerve and extensor digitorum longus followed by peroneus tertius. So all these tendons with the anterior tibial vessels and nerves. So structures passing deep to the extensor retinaculum. They form the anterior relations. So the cross section at the region of ankle, you will be able to see tibialis anterior, extensor hallucis longus, extensor digitorum longus, anterior tibial vessel and deep peroneal nerve, laterally peroneus longus and brevis. You see the short saphenous vein and sural nerve. Here you see the long saphenous vein and the saphenous nerve. So structures passing deep to the flexor retinaculum. Tibialis posterior, flexor digitorum longus, posterior tibial vessels and the tibial nerve, flexor hallucis longus. This is tendocalcaneus. Now we will be able to get an orientation of the structures around the ankle joint, which forms your anterior relation, posteromedial relation, posterior and lateral relations. So posteriorly I told you the tendocalcaneus along with the plantaris, and more deep you will have posterolaterally the peroneus longus and the brevis muscles. Posterolaterally, posteriorly. Posteromedially, structures passing deep to flexor retinaculum. Tibialis posterior, flexor digitorum longus, posterior tibial vessels, tibial nerve, and flexor hallucis longus. So relations of ankle joint in front, structures passing deep to the extensor retinaculum. Posteromedially you can write structures passing deep to flexor retinaculum. Posteriorly you can write tendocalcaneus, and laterally or posterolaterally it is the peroneus longus and brevis. The movements permitted at the ankle joint is mainly the dorsiflexion and the plantar flexion. So dorsiflexion when the toes are pointing upwards, and plantar flexion is the toes are pointing downwards. During dorsiflexion, the angle between the leg and the foot decreases. There is a decrease in the angle between the leg and the foot during dorsiflexion. During plantar flexion, the angle between the leg and the foot increases. The range of dorsiflexion during normal movements is 10%, and when the subtalar joints are involved, or when the tarsal joints are involved, the range is again increased to the 20 degrees. From 10 degrees, it is increased to 20 degrees. Now, during dorsiflexion, what happens is the joint is in a closed pack position, which means the joint is stable, because the anterior part, trochlear surface of talus, is extensive and broad, that comes in contact with the tibiofibular mortise during dorsiflexion. Maximum congruency of the articulating surface is there, so naturally it is in a closed pack position. Associated movements are adduction and abduction, which again is more pronounced during the plantar flexion. So muscles which is producing the dorsiflexion is tibialis anterior, extensor hallucis longus, extensor digitorum longus, and peroneus tertius. The opposite movement of the dorsiflexion, it is checked by the antagonistic muscles, mainly the tension of the tendocalcaneus, and by the stretching of the ligaments, mainly the posterior fibers of the deltoid ligament and calcaneofibular ligament. So this calcaneofibular ligament and the posterior fibers of the deltoid ligament, which is from the medial malleolus to the medial tubercle of the talus. So these two ligaments, when they get tensed, and when there is a tension in the tendocalcaneus, that checks or prevents the further dorsiflexion. Plantar flexion, when the heel is raised off the ground, it is mainly responsible for the forward thrust, okay, pushing forward during your movement. Especially when you run, you can see only the toes touch your ground. Are you able to understand? Only when the toes touch your ground, and range is only 20 degrees and can be increased when assisted by the tarsal joints. Loose packed position. The joint is actually a loose packed position, and accessory movements possible is the adduction and abduction. So that is why it is a modified hinge joint. So when it is loose packed, it is prone for dislocation, especially in females who wear high heels. Their foot is always in a plantar flexed position. Plantar flexed position. Okay. So because of that, they can walk fast, but there is prone for dislocation, anterior dislocation. It is prone for the anterior dislocation when we wear high heels. And because during plantar flexed, what happens is there is always an intermittent contraction of the tendocalcaneus. So your calf muscles will be toned your calf muscles, especially your gastrocnemius soleus, is toned and stiff. So naturally what happens is it gives a very good shape to your calf region. So that is one advantage of wearing high heels, but mainly prone for dislocation. So main muscles, tendocalcaneus, so naturally gastrocnemius and soleus, assisted by the tibialis posterior, flexor digitorum longus and flexor hallucis longus. So too much of plantar flexion is again checked by the anterior fibers of the medial ligament, the spring ligament, and the anterior talofibular ligament. There actually it is the calcaneofibular which checks the dorsiflexion. Here plantar flexion is checked by the talofibular ligament. So comparatively a very strong joint, so because of the close interlocking of the anterior surface. So you have seen not only there is superior inferior articulating surface, even at the sides it is locked by the articulating surfaces of the medial and the lateral malleolus, tibiofibular mortis, and which has the corresponding articulating surface on the talus, the comma shaped facet and the triangular facet. So interlocking is very much firm, and you also have the ligaments, and numerous tendons are crossing the joint. So they act like what do you call, some like a tie beam which is holding the joint on all sides. So this stability is maintained mainly by the tone of the muscles, the articulating surfaces. The line of gravity for the ankle joint passes slightly in front, so more prone for the forward dislocation, but this, as I told you, is prevented by the broad anterior surface and tonic contraction of the triceps. So triceps from behind, triceps surae from behind is rendering a very great support for the ankle joint. In front, what happens, what you have is the broad articulating surface of the talus. So this actually compensates to some extent for the forward dislocation, but any direct blow or any trauma can definitely dislocate the joint anteriorly. Ankle sprain. So during excessive inversion, when the foot is inverted with the plantar flexion of the ankle, okay, plantar flexion and inversion, usually plantar flexion is associated with inversion. What happens is there is an injury to the talofibular and the calcaneofibular ligament. They are actually torn. So ligament sprain can occur, or ligament might get damaged or injured. You see pain and swelling over the ankle region. Okay, that is mainly the ankle sprain, mainly due to the sudden inversion with plantar flexion. Acute sprain, what happens is along the medial side of the ankle, it is very less common because injury to the medial or deltoid ligament not occurs very often, or not so prominent, and if at all it occurs, it might be due to the result of excessive eversion of the foot. Okay, so that is mainly about the acute sprain, because damage to the medial ligament during excessive eversion. The other one is the ankle sprain. This is acute sprain in the ankle due to the damage of the medial ligament. Pott's fracture. So any force of impulse which is going to push the talus against the lateral malleolus leads to fracture of the fibula and also the medial malleolus. So fibula is fractured above the ankle joint. It might be a vertical or an oblique fracture, and the medial malleolus is fractured transversely. This type of fracture is actually called as the Pott's fracture. mainly occurs in sports, recreational sports, your baseball. So here you are able to see the direction of the impact and the direction of the movement. Okay, so the impact where the talus is actually impacted against the lateral malleolus of the fibula. Because of that, there is actually a fracture of the fibula little above the ankle joint, and here you are able to see the medial malleolus of tibia. There is a transverse fracture. This is actually called as the Pott's fracture. So here you are able to see how it is impacting talus against the lateral malleolus of fibula. So a radiograph of the ankle you are able to see here. Lower end of the tibia with the medial malleolus, fibula with the lateral malleolus. Lateral malleolus of fibula is at a lower level. The epiphyseal line of the lateral malleolus corresponds with the ankle joint cavity. This is the trochlear surface of the talus, and you see the comma shaped facet medially, and this side of course it is not seen, is the triangular facet. Navicular bone you are able to see, sorry, this is the calcaneum bone, posterior heel, posterior surface of the calcaneum. This is your navicular bone which you are able to see here. Talus and calcaneum, there is a space. The calcaneum sinus tarsi is actually seen. Okay, this medial projection on the calcaneum is actually called as the sustentaculum tali, and this is the head of the calcaneum. Calcaneum and navicular, talocalcaneo-navicular joint. Talocalcaneo-navicular joint actually forms your mid-tarsal joint. Posteriorly, you are able to see between the talus and the calcaneum is actually called as the SUBTALAR joint. Okay, so that is the navicular, and then they are the cuneiforms, medial, intermediate and lateral cuneiforms. You are able to see in the radiograph. This is the malleolar fossa of the fibula. Okay, coming to the mid-tarsal and transverse tarsal joint, mainly mid-tarsal joint, you see the talocalcaneo-navicular joint. The head of the talus you are able to see here, and the calcaneum, they articulate. It is actually a ball and socket joint. Between the head of the talus and the navicular is actually a ball and socket. Calcaneo-cuboid joint is actually saddle variety, reciprocal concavo-convex. Reciprocal concavo-convex. So this is talocalcaneo-navicular. Posterior part of the talus along with the calcaneum will form the SUBTALAR joint. So mainly what happens between the mid-tarsal and the SUBTALAR joint, the inversion and eversion takes place, especially more pronounced. In major part of inversion and eversion is taken care of by the mid-tarsal joint. So, sorry, the SUBTALAR joint. So that is why we are actually going to discuss about the SUBTALAR joint. So it is also called as the posterior talocalcaneal joint between the posterior part of the talus and the calcaneum. Multi-axial joint. Okay, it is actually a multi-axial joint, more than one axis or more than two axes. So concave facet on the lower surface of the body of talus, convex facet on the upper surface of the middle third of the calcaneum, and you have the sinus tarsi. So the ligaments of this you are able to see concave and the convex facet. Lower surface of the talus you have the concave, and this you have the convex facet. Talocalcaneal ligament, medial and lateral talocalcaneal ligament. Then you have the interosseous talocalcaneal ligament. Okay, so that is the interosseous talocalcaneal ligament, and then you have the cervical ligament. interosseous talocalcaneal, cervical and medial and lateral talocalcaneal ligament. These are the ligaments concerned with the subtalar joint. So this interosseous ligament fills up the canal of sinus tarsi. I have already been telling about the sinus tarsi which is present in the calcaneum. So here you are able to see the interosseous ligament. The interosseous ligament separates the anterior and posterior articular compartments of the calcaneum. Okay, anterior and posterior compartment is actually separated by the interosseous ligament since it is present between the bone. So this is going to be the calcaneo-navicular articulation. Okay. So cervical ligament is actually present lateral. Here you are able to see lateral to the cervical, lateral to the interosseous ligament. You see the cervical ligament, which connects the calcaneum with the neck of the talus. Okay, which connects the calcaneum with the neck of the talus. Movements in the subtalar joint is the inversion and eversion. Inversion is where the medial border of the foot is raised, and eversion is where the lateral border of the foot is raised. Okay, so this is associated with the dorsiflexion, mainly inversion and eversion. During walking on a flat surface, we don't expect inversion and eversion, but when we are walking, especially on an uneven surface, then for foot has to adjust for the uneven surface. So there what happens, inversion and eversion of the foot takes place. So mainly the axis of inversion and eversion passes obliquely upwards, forwards and medially. From the calcaneum to the talus, it will pass upwards, forwards and medially. It is actually an arc passing through the center of two joints, that is the mid-tarsal as well as the subtalar joints. When you join these two, then you get the axis of this joint. So from the end of the calcaneus to the sinus tarsi, I told you, to the talus, the axis passes above, forwards and medially. So inversion of the foot is mainly by the tibialis anterior and tibialis posterior. When inversion is taking place, when inversion is actually taking place in the mid-tarsal joint, then naturally there is also a supination at the subtalar region, some amount of adduction. When there is eversion, what happens is you also have the pronation of the foot. But since supination and pronation takes place, it cannot be exactly compared to the radio-ulnar joints. So your tibialis anterior and posterior muscle brings about the inversion, whereas the peroneus longus and brevis muscle brings about the eversion of the foot. Okay. So with this, I have completed the subtalar joint, the ankle joint and the tibiofibular joints. So thank you very much for your patient listening. We will meet again in the next lecture.